I'd like to introduce our final speaker. It's Dr. Kathleen Wong, Associate Professor at the University of Pittsburgh School of Medicine and Director of Male Reproductive Health. She completed her residency in urologic surgery at the University of Virginia Health System and her fellowship in male reproductive medicine and surgery at Baylor College of Medicine. Her research focuses on new biomarkers of sperm health, new treatment modalities for Peyronie's disease, and male fertility preservation in all ages. Thank you.
I'm a lot shorter. I'm going to lower this down. Hi, everybody. Thank you so much for the opportunity to talk about our work. I am a clinical urologist, and I feel very fortunate to be here today. I am going to talk to you and hopefully tell a story about our ultrasound-guided rete testis sperm aspiration. And as a potential path to spermatogonal stem cell transplantation, so this is another male talk, so be very excited about that. All right, here's some disclosures, but I'm sort of preaching to the choir, right? So here's spermatogenesis. This is a very complicated, lots of different steps, but obviously very, very important different steps to get to our mature spermatozoa. And this is a priority for all of us, our ability to get to that last stage, to be able to help couples achieve conception, pregnancy, babies. And there's a lot of different aspects where different mechanisms are kicking in, and so this is not that easy to replicate, but this is our goal, to be able to start from the beginning and work all our ways down to that mature spermatozoa. Now, from the anatomy of the testis, this is a quick, brief review, right? So it's a really complicated structure. Seems pretty simple. Most folks don't know much about it, but here we go, right? Spermatogenesis happens in these seminiferous tubules, and if you look at the architecture of the testis, we describe this to our patients like it's like almost like an orange. There are different segments, and each segment has all these tubules that work amongst each other, but then they all filter into what's the rete testis, where all that developing sperm are going to work its way on up towards the epididymis. Now, fertility after cancer, this is, again, quick, brief review, right? So basic background. We just heard an amazing talk about gonadotoxicity and all these treatments that are there to help folks achieve survivorhood from cancer. But unfortunately, they can cause infertility. Adult women and men, they have the wonderful opportunity to cryopreserve both eggs, sperm, and even embryos, which then can be used in the future to help them achieve this pregnancy. However, these options currently just really aren't available and weren't available for pre-adolescent boys and girls who are not yet producing mature eggs and sperm. And thankfully, the 5-year survival rate for pre-adolescent cancer patients is getting higher and higher. So all of a sudden, this becomes such an amazing opportunity to help these patients. Prepubertal boys have spermatogonial stem cells in their testes, and they're literally poised to initiate sperm production at puberty. And at this point, we just heard centers worldwide are preserving testicular tissue for boys, ovarian tissue for girls, in anticipation that someone, hopefully in this room, is going to find those new reproductive technologies that will be able to help them in the future. So when we think about this, this is a lovely figure from Kyle. Fertility preservation for boys with cancer. But to start with, this is what adults can do, right? Kind of protect their fertility, produce a masturbated sample, cryopreserve, wonderful. But again, as we just mentioned, not really an opportunity for pre-adolescent boys. So then we have different opportunities. If you have stem cells, what can you do with them, right? Cell suspension versus testicular tissue, grafting opportunities, and ideally, all couples want to try to conceive naturally. That's sort of like their end goal. But what if you couldn't get there, but you could also find sperm, help them mature sperm, kind of have that biological sperm, and that can be used with assisted reproductive techniques. And another opportunity is if you don't have single cell suspensions, how about just good old-fashioned testicular tissue grafting? And again, another opportunity is sort of that induced pluripotent stem cell, right? Grab a piece of skin, make them some stem cells, flip them, and then again be able to potentially find that sperm. So this is what I would consider like an iconic figure, right? Like even anybody who's not really into fertility preservation, they've seen this before. We've talked about this in residency. This is Brinster's figure. And for me, I've always thought of this as like just that super powerful assay that allows you to kind of see what happens with male germline stem cells from the donor. Then you think about what happens with the stem cells in the recipient testis. But I think for me, mostly, you kind of get to understand and evaluate and assess what happens when you mess with those stem cells in vitro and then go ahead and put them into a recipient. So a beautiful, powerful assay that really kind of started us on, wow, we can actually do this. In fellowship, when we think about these type of things, right, that was in a rodent model versus a primate model, which we're going to talk about next. And the whole point about this is I'm telling you a story about how this has led up to what we're doing now. So even for me, this was me in fellowship, tinkering around with stem cells and trying to see if I can get these to inject, right? So this is a micropipette pulled, and this is in a mouse, and this took many a try, but we finally got it. Thank goodness someone took a video of it, because I proudly show this video every chance I can get. And you can see how awesome is that? This blue, methylene blue infused solution, you're filling that seminervous tubule one by one. How cool is that, right? So this is the injection through the efferent duct. Not so easy. You have to take the testicle out, right? You have to expose it. So this doesn't seem like that great of a thing to do in patients as a consistent reproducible thing. So here, I'm going to switch very quickly to how Kyle sort of introduced an ultrasound-guided, minimally invasive. We still need a needle, but there's no big incisions. This is an ultrasound-guided access to the testis. Now, if you look back and remember to that sort of figure of the anatomy, that rete testis is kind of like that central region where all of that, most mature sperm in the testis kind of pool into. And so that rete testis on ultrasound is that bright white stripe. And so what you're going to see is this needle coming in, look at it, big bad needle, but you can access this rete testis in a safe way without puncturing in it. And the solution that Kyle's using here is sort of laced with something called Optison. Optison is something that echocardiographic stuff works with. They're little microspheres, and they're filled with air. And so once it hit, it shines bright and white, and you'll watch that in a moment. So the white itself, boom, isn't that exciting? It's like lightning. But that tells you you're in the right space, it's not spilling out anywhere, and as you continue to watch, you're gonna see the solution backfill into those seminiferous tubules. And this is that parallel to that blue methylene blue filling individual tubules, which is very exciting. Okay, then he went on to prove that after injecting those stem cells, you can regenerate spermatogenesis in this primate model. So after this, the thought is, okay, can we do this in humans? Can you even find a rete testis on ultrasound in a human? So these are representative ultrasound images from a 16 and a 17-year-old boy, and there it is. It's pretty straightforward. It's identifiable. Step one. Can we find it? So then if we're going back, I'm going to take a moment back to tell that next piece of the story. If we're looking at grafting opportunities, right? And so I'm going to tell another story from Kyle's lab. And this is from, I think, a publication in 2019, right? So autologous grafting of prepubertal testis tissue. So you have a single monkey, they give up a testicle, you freeze it, they undergo chemotherapy, very toxic, and then you give them that tissue back later. Here is their sort of game plan, looking at different opportunities and different variables of how to graft that tissue, whether it was fresh, frozen, matrigel, no matrigel, all of these sort of algorithmic things. This, histologically, with beautiful staining, tells you what it should look like in an adult rhesus testis, right? This is what it looked like pre-graft, right? So this is the histology of that sort of barren testis ready to have those injections of those stem cells introduced. And here are sort of the graft growth and appearances, right? So they're tracking it, and this is published, but look at these beautiful pictures. And I remember the first time speaking to Kyle about this, and he was so proud, and he even labeled them the little testicles. They made new little testicles, and they were very proud about that. But that's incredible, right? Like grafting this material, testicular tissue, watching it grow, watching the different sort of biological assays, looking at testosterone levels, and then finally saying this is a recovered graft, almost a year out from when it was originally grafted. And while it doesn't totally look like a testicle, if you just sort of squinted at it, you would say there is some architecture starting to form there, right? And if you look at the magnified level, there's some tubules starting to be visible there, right? So very exciting stuff. Then, this is complete spermatogenesis from these autologous grafts. They even have a picture of a sperm, right? Mature sperm there. Then what did they do? They went on to do ICSI. So they did ICSI with that sperm, made a monkey baby, right? And then embryo transferred, healthy pregnancy, and then they have Grady. So this is the graft-derived baby born in 2018. Kyle so very lovingly gave me this video of watching Grady play with her auntie, which is very cool. So alive and well, doing well. So now we've just showed you, is there a real future for stem cell cryopreservation and transplantation? Yes, I believe there is. Right, so what next? If testicular tissue grafting is possible, check. What should we do next? I feel like we should repeat the experiment in animals with testes to model the pre-pubertal cancer survivor, right? We're gonna try to make this even more translational each step that we go. So, this was a study just published just last year in 2021. This is Gunapal Shetty and the team down at MD Anderson. They had 6 pre-pubertal recipients, okay? So again, these are primate models. They had a unilateral orchiectomy or castration. Then they had radiation. They waited until they were post-pubertal. Radiation again. And then different time frame, right? Watch. The original cryopreserved testicular fragments were dissociated cells. They also had all these type of things. I'm just going to tell you, this yellow star is when I joined the University of Pittsburgh team, right? So this is when I started to talk to Kyle and talk to all these folks in these wonderful kind of projects about how I could get involved and help with this. Here is when we went to Houston, and this is where I learned how to do the rete testis injection, the aspiration, and I worked on these animals with Gunapal and Kyle. So it's busy table, but nonetheless, something that always kind of stuck with me is when you're thinking about, okay, they're re-injecting these cells. I was learning that technique, we did it all, but look at the number of cells that were injected in each of these animals, right? Pretty high numbers, and that was like, okay, I want to keep that in the back of my mind. And I'm showing you the same video, but in this meanwhile, think about what we're doing. Instead of just injecting, at the same time that we sort of accessed for myself, my job was to get the needle into this space, but rather than inject and introduce the stem cells, it was rather to also pull back to see if I could pull sperm out from this section. So these are animals that had already had the stem cells injected. And I was there on the day of harvest to kind of pull all those fluids out, pull all those tissues out. So this is a representative testicle from one of the primates, and we cross-sectioned it, right? And boom, 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 you can see lots of that. Ooh, sorry. But you can see kind of like that spoke wheel pattern of that methylene blue solution kind of distributing throughout the architecture of the testis itself. And it sort of like made us feel really good and really proud that like we got into the right space. Yay me, I was very proud of myself. But this was sort of a, okay, we're doing what we think we're doing. Now, if you look at the data, originally they were able to get ejaculates from each of these 6 samples, monkeys. And you can tell, none of the ejaculate, right? But very low volumes, right? How consistent, how easy is it for you to get a really great ejaculated sample from a primate? It's not that easy, but it's feasible. But when you look at what we did next, which is on the day of aspirating that sample, we were able to find sperm in that rete testis. Not in all the samples, but in 4 out of the 6, which is pretty amazing. And some of them had pretty high numbers of sperm. So clearly we were able to access that space. We were able to aspirate out mature sperm. Now, when we look at also, this is another form of that same data, but if you look at number 6, 61% donor, right? Pretty awesome, and pretty high numbers of sperm aspirated from that rete testis. And here, if you look close enough, that one sperm in the middle is actually twitching. Okay, so that's incredible, right? You have actually a twitch in one of these mature sperm. It's subtle, but I'm sure you can see it. So they did ICSI as well. They were only able to get this particular embryo out to about the compact morula stage. They never got any blasts, but this is pretty awesome. Almost. We almost got there. So I don't have any other monkey babies to show you. It was only Grady. But there's that sperm, and it looks pretty viable. It looks pretty good. Good morphology, kind of exciting. So what next? We just talked about the testicular tissue grafting, check. We repeated the experiment in animals with testes to model the prepubertal cancer survivor, pretty good. So what about humans? Do you think we can do this in humans? What are we gonna do? Are we injecting the cell suspension? Are we gonna graft testicular tissue? And this is where we are now, right? We're talking cell suspension versus testicular tissue. But first steps, like any IRB, is can you actually do this in a safe way? So we needed to prove that the technique of accessing into the rete testis in an adult male human is feasible, reproducible, and doesn't really cause a ton of adverse events and side effects, right? So we have a rete testis aspiration study. So what patient population is actually going to let me stick needles into their testicle? So that's a thought, right? So the infertility population, they're asking me to do that anyway. So infertility patients with azoospermia tend to be sort of the severe male factor, right? That non-obstructive azoospermic, right? So that non-obstructive azoospermic patient is the most severe male factor, and it's a production issue. Something's wrong with their sperm factory. Then you have the obstructed azoospermic patient who has a plumbing issue, right? The sperm factory works great, but there's a plumbing issue. So those are two ideal patient populations who are coming to me clinically asking me, can you find me sperm so we can use it for IVF ICSI to help conceive a child? And another aspect, we talk to those patients about participating with the study, but also, do you want me to combine this with your otherwise considered standard of care? Right? For the NOA, non-obstructive patient, that would be a microdissection testicular sperm extraction. For the OA patient, that would be a testicular sperm aspiration, right? Simple, straightforward. And for some they did, and for some they didn't. So currently right now, we have 8 patients who have agreed and have had the rete testis aspiration. 5 of them were in the NOA, and that's the production patient, severe male factor. And 3 were in the obstructed. And these are, again, that's the plumbing issue, normal sperm production otherwise. Then subsequently, there's an IRB that's approved for spermatogonial stem cell transplantation, injection, and tissue grafting, right? So here is sort of a very busy table, but this tells you a little bit of detail about these patients. And you can see the age range, you can see what their diagnosis was, whether sperm was found or not. And what you can look at is there's variable numbers of sperm that are being able to access from the rete testis aspiration. So what we learned from this certainly is I can get into the space consistently. Nobody had any adverse events. There was no hematomas, no infection. They did great a day or so with a little ice over the scrotum, and they were fine. But here's a little bit more detail. So if you separated the patient population, the NOAs, there are 5 patients. No sperm was identified on any of these patients via the rete testis aspiration, okay? 3 had elected to combine it with their microtestis, and that's considered kind of the gold standard. 1 of those patients had sperm identified and cryopreserved after having that microtestis. In the obstructive azoospermic patients, we had 3. 3 elected, all of them really, to combine it with a TESA, which is again that kind of gold standard way to aspirate sperm for ARTs. All 3 patients had sperm aspirated from the rete testis, and then sperm are frozen into separate vials for them, meaning rete testis aspiration, TESA aspiration. None of them have actually used them yet, but they're still cryopreserved. Now, what this told us is we can kind of get into the right space. The NOA patient population probably isn't the best population to validate this because they probably don't have enough sperm for us to find it. But nonetheless, we were able to proceed with this and do this. Here are ultrasound images of those particular sampling of those patients. He's a 33-year-old on the top panel. He's that non-obstructive patient, no sperm were found, but you can see the rete testis. On the bottom is another NOA patient. Sperm, this was the one where sperm was found, and you can see the rete testis again. And you have to keep in mind, patients who have NOA have very, very not normal testicles. These are testicles in an adult male that are about 8 to 10 cc's, right? So very small, not normal size for an adult male. And so that was a little bit of my concern, is whether or not their testicular architecture was going to be predictable, that kind of thing. So I'm probably jumping ahead a little bit, but to give you a perspective of what Kyle has been building at Pittsburgh, the cryopreserve since 2011, I think as of like 2 weeks ago, it was testicular tissue of 499 boys, ovarian tissue 189 girls, obviously the mission that is there. Here is the team in itself. Big team, great people, we're doing some fun stuff together. So here's our ongoing phase. So we have this IRB approved study. We have spermatogonial stem cell transplant and testicular tissue grafting, and we're at the patient selection phase. We have a total of 67 candidates to potentially evaluate, right? That's after that first screening, second screening, and 67 of those patients are now on a short list. And the goals are trying to identify who's that first ideal patient to kind of bring back in to do this stem cell transplant and grafting. And for me, because I think for me, obviously we want to bring someone who's hopefully local, that makes it a whole lot easier, versus someone who's living in Australia, that makes it more challenging. But if we could find a local candidate, that would be great. A non-malignant candidate would also be kind of cool too, because then I don't have to worry and not sleep at night. And then whether or not we have patients who have just cell suspension, who just tissue for grafting, or someone who has both. So these are all logistics that are currently being thrown around to help figure out who's that next best thing. And then there's laboratory optimization things, all these type of things that are working through. Here's a quick kind of tissue grafting, sort of that algorithm, and there's like different steps, different studies, all these type of things. But nonetheless, we're hoping to get started relatively soon. So future directions are, ideally in a perfect world, I would love to see us repeat that experiment with their primates and be able to achieve a pregnancy, because that's like the best step. And now we are extending some of these studies to these human patients, and this sort of is that final stage of that story where the rete testis aspiration has shown to be a viable way to access the testis and deliver these stem cells in a safe way. And what we're hoping to do is to prove that in adult males, hopefully. Great, thank you.
That wonderful talk. I'm Julie Rios, also from UPMC. 2 questions in regards to the embryo that only made it to the morula stage. Was there a concern, sometimes with male factor infertility, we'll see in the lab that embryos don't often bypass or progress to the blastocyst stage. And is there any studies to kind of look at that as to, is that the underlying cause? My other question is, in accessing the rete testes from infertility, for our obstructive azoospermic patients, would that allow for more conventional insemination in the lab because you have more mature sperm, or would you still recommend ICSI with IVF?
So I'll answer the most recent question. So even if we were to access sperm and be able to pull out, a decent number of sperm from the rete testis, they still haven't gotten to the epididymis, right? And so the epididymis is kind of like that final stage of true maturation where they're learning to swim and learning all those wonderful things on how to find the egg. And the reality is you're never going to find enough sperm from a rete testis that is going to preclude a patient to be able to have more than one IUI cycle. Right? And so the likelihood that this is a viable thing long-term for multiple couples to be able to conceive is probably not relevant. So that rete testis aspirated sperm is great, but still probably for ICSI, okay? From the compact morulophagus thing, so I don't know super details about what Gunopal is doing next for those things, but that was like a very big clear thing that he was a bit frustrated about, that they couldn't get it past that morula stage. And I totally hear you about what was it, the sperm? right? Like, what are they doing about those embryos to try to figure out if anything? And I'll have to ask, I don't know. Maybe Kyle knows, do you know? Don't know.
Hi, fantastic talk. And I think this is really, really exciting time for the male fertility preservation field. I think we're on the cusp of something incredible. So I just wanted to touch on something that was mentioned a bit in the male committee meeting yesterday, which was the timing of the transplantations. So at what age are we going to be doing this? Are we going to be doing this in advance of individuals wanting a child wish? So younger, perhaps, ages. And then the second question is, how long are we going to leave cells or tissues in before we start trying to retrieve sperm or retrieve the tissue to extract sperm? The logistics of the timing of those two things, I think, is a question.
I don't know that there's a right answer. Kyle and I have talked a lot about this, and we've both felt that, like, the younger the better. Myself, for purely selfish reasons that I can find the rete testis on an ultrasound, the younger that they are. And that's just an anecdotal thing. I don't have like an N of thousands that I can tell you about. But of the testicular ultrasounds that I've done, and granted, I probably haven't been paying always to attention of where's the rete testis, but that certainly has been the priority in my mind of every ultrasound of the testis I've ever done in the past 3 years now. So I'm always looking for the rete testis just purely so that I can say, okay, I'm starting to get a pattern of where we are. And what I've noticed is the younger that they are, it is certainly much easier to say, boom, there it is. It's a clear, wow, that's beautiful. And I didn't even have to think hard about it, right? Some of them, and again, most of these patients that I work with are infertile, right? And so they're not your average random population. But the smaller the testis that they are, the older that they are, the more Semele factor, the harder it is for me to find. And so I'm very much hoping for a younger patient population, like 18 would be ideal. I would love that. A teenager, a late teenager, early 20s would be awesome. That would be a fantastic ideal target for me. The timing of like what to do once it's in, I don't know. I mean, I'd leave that up to Kyle. He has the most experience about talking this, when to graft it, when to look, all that kind of stuff. But we're just learning as we're going along. So I'm hoping to have more information about that, within the next year or two. That would be ideal.
Thanks.